On behalf of APLAR, I'm Dr. Himantha Athukorala. Welcome to the 4th APLAR Grand Round. APLAR Grand Round is an activity of the APLAR Academy. The theme for today is shedding light on myositis. This is a case-based discussion. Let me now introduce our speakers. Seated right next to me is Dr. Amal Sithira Tilakaratna, the APLAR young rheumatologist who will recall his experiences in managing a very unique patient. Dr. Amal works as a consultant in rheumatology and rehabilitation at District General Hospital, Matale, Sri Lanka. And seated next to Dr. Amal is Dr. Dominda Munidasa, consultant in rheumatology and rehabilitation at Rheumatology and Rehabilitation Center, Ragama, Sri Lanka. Dr. Munidasa will lead our guest faculty. Dr. Harshima Vijayasinghe, a consultant histopathologist and a senior lecturer at Department of Pathology, Faculty of Medicine, University of Colombo, Sri Lanka, is another member of our eminent guest faculty who will guide our case-based discussion with her expertise. Dr. Chintaka Apuhami, consultant radiologist and senior lecturer at University Surgical Unit, Faculty of Medicine, University of Kalniya, Sri Lanka, is also a member of our guest faculty. Dr. Chintaka will lead the discussion along radiological aspects. So without further ado, I will hand over the forum to Dr. Amal to present his case. The stage is all yours, Amal.
Thank you very much, Himantha. So I'll be presenting on a case I first came across in November 2021. And in fact, this patient was referred to me from the dermatology unit. And she is a previously healthy 45-year-old female who presented to the dermatology unit with a 6 weeks history of a pigmented rash over face, upper chest, and hands. Furthermore, she had a progressively worsening difficulty in getting up from the squatting position, raising her arms, and climbing stairs for the same duration. At the time of the first consultation, she was unable to walk, wheelchair bound, and needed assistance to carry out activities of daily living. She also reported on constitutional symptoms such as fatigue, non-intentional weight loss of half a stone, and intermittent low-grade fever. She had no breathing difficulties, swallowing difficulties, or bulbar muscle weakness. She had no other symptoms of a connective tissue disease or inflammatory arthritis. In view of the muscle weakness, I have also looked into a possibility of an endocrine disease, and she had no features of thyroid dysfunction, cortisol excess, or acromegaly. She is a statin-naive patient and denied any history of recreational drug use or native or herbal treatments. She is from a healthy family, and she is a mother of 3 kids, and she had no further fertility wishes. So this is a picture of her on the initial presentation. You would appreciate that there was a hyperpigmented rash across her face as well as upper chest. And she has periorbital edema or swelling as well. This was a photo of her upper chest, and she had a hyperpigmented rash mimicking a V sign. In addition, she had the same hyperpigmented rash was there over her upper arm, suggestive of a sleeve side. And you might appreciate that she had some Gottron papules as Gottron signs, and there were ragged nail cuticles as well as nail fall infarcts. Furthermore, in the examination, she had no any other feature of connective tissue disease. She had no lymphadenopathy. Breast examination, there was no breast lumps. A digital rectal examination and the pervaginal examinations, there was no significant findings. Her cardiovascular, respiratory, and abdominal system examinations were normal. Furthermore, there was no distal muscle wasting, and all reflexes were present. And I proceeded with the MMT-8 scoring. And as you see, I have looked into 3 muscle groups: axial muscle group, proximal muscle groups, and distal muscle groups. you would appreciate that there was a symmetrical weakness in proximal muscle groups, and when it comes to distal muscle groups, they were fairly spared. And she had a MMT8 score of 99 out of 150. So in summary, I was talking about a 40-year-old female severely disabling with severely symmetrical proximal muscle weakness of all limbs progressed over 6 months. She also had a diffuse pigmented rash of face, arms, thighs, and hands, and these skin lesions were suggestive of Guttron papules. So we came to a working diagnosis of dermatomyositis.
Thank you, Dr. Now, I would like to know from Dr. Duminda Munidasa, consultant rheumatologist, about the idiopathic inflammatory myopathies classification, diagnostic criteria, and the initial investigations that we should probe into.
Thank you, Mark, for that presentation. And yes, your patient definitely have all the features to suggest dermatomyositis, which we know belongs to a group of disorders now we classify as idiopathic inflammatory myopathies. Other than dermatomyositis, this group include polymyositis, juvenile dermatomyositis, clinically amyopathic dermatomyositis, antisynthetase syndrome, immune-mediated necrotizing myopathy, and inclusion body myositis. So this is supposed to be a heterogeneous group of autoimmune muscle disorder primarily affecting symmetrical proximal muscle weakness. So, and it's a rare disorder which worldwide reports of about 14 per 100,000 adults, and we get a juvenile type at 5 to 15 years old children, and then later commonly after 45 years of age. Most of them are more common in women other than the inclusion body myositis. And you can have monophasic presentation, relapsing presentation, or persisting presentation. And importantly, it's not only muscle, commonly it involves skin, as well as you can have lung, cardiac involvement, as well as underlying malignancy is been or more common or more associated with malignancy has been well known in this group. So when we want to make a diagnosis, all of you are, I'm sure, very much aware of what we use traditionally is Bohan-Peter criteria for the dermatomyositis and polymyositis diagnosis, which we look at 5 areas, and depending on what is present, we would call it definitive dermatomyositis polymyositis, or probable or possible. So we have this symmetrical weakness of limb girdle muscle weakness, as well as anterior neck flexor weakness. We should have muscle biopsy evidence of myositis, elevated muscle enzymes, especially CPK, but it can be aldolase or AST, other muscle enzymes. Typical features EMG, which I'll describe later, and then typical dermatomyositis rash, including heliotrope or Gottron's papules, as well as Gottron's sign. Of course, those are the diagnostic criteria. When we come to classification for trials and other purposes, we can use the EULAR ACR 2017, which look into different domains: the clinical muscle variable, skin, other variables such as the dysphagia or esophageal dysmotility, laboratory variables, and muscle biopsy variables. And using a weighted grading of for all these, we make a classification into as a definitive idiopathic inflammatory myositis. Looking at the EMG, which we commonly associate whenever we get a muscle weakness, we think about doing an EMG, and generally it should be actually done together with nerve conduction and EMG. What my electrophysiological consultant will tell me is that they can actually look and say there are 3 things: whether it's normal muscle, which will have this biphasic or triphasic appearance, whether it's a neuropathic variety where you get the fibrillatory type of high velocity spontaneous actions, and the myopathic, which is characteristically described as short duration, low amplitude, and polyphasic, which you see here. And so, though we think whether the EMG can tell us, gives us a diagnosis, it's not so, according to the electrophysiologist. These abnormal features do not really distinguish whether it's inflammatory myopathy from other myopathies, which also can have this muscle membrane instability, giving a similar picture. They are also often seen, similar changes are also seen in toxic and necrotic or infection associated myopathies, and sometimes even congenital or metabolic myopathies, as well as muscular dystrophies and myotonic disorder. So it can, if you straight away go and this EMG and decide that try to get a diagnosis, you might get into a confusion in the making a correct diagnosis. So it's always said that electrodiagnostic studies in this type of patient should be only an extension of a history and physical examination. So after you do your physical history and take the history and physical examination, make a possible differential diagnosis, then you think whether you need to go for EMG, or whether if it suits more like a genetic issue, you can straight away do the genes, or maybe the biopsy, whether it comes predominance to the EMG. So it's very important how you interpret EMGs in this setup. For example, the inclusion body myositis will actually give you a combination of neuropathic and myopathic pattern. You may get a normal EMG with steroid-induced myopathy, and also you might get a normal, even if you get a normal electromyogram, that does not exclude myositis. So these are few things that we have to keep in our mind whenever we see such a patient and think about diagnosis or investigation. But it's good, and it helps us to exclude neuromuscular condition that may mimic a myopathy sometimes, and provide EMG evidence of presence of myopathy for your classification or diagnostic criteria, and also it tells us whether what's the distribution of muscle involvement, whether it's proximal distal, symmetrical or asymmetrical, which sort of suits us, giving us a differential diagnosis within the group of idiopathic inflammatory myositis. The presence or absence of abnormal spontaneous activities and severity also can be sometimes graded with the EMG, which helps in your prognostication and choice of treatment. And also very importantly, it can identify targeted muscles for the biopsy. Ideally, the teaching is that you should do a biopsy from non-EMG muscle, because there can be changes which might interfere with the histopathologist to interpret. So there is a guidance to say that best things when you suspect this and want EMG, you ask the electrophysiologist to do on one side of the body, so that when you want to do the biopsy, you do the opposite side, the similarly affected muscle. So,
thank you, Dr. Duminda. Now I would like to invite Dr. Chintaka Puhami to speak about the role of imaging in myopathies, idiopathic inflammatory myopathies. Over to you, Chintaka.
Thank you, Himanta. Can I have the slide, please? Right, the role of imaging in myopathies. So we have different imaging techniques that have proven useful. Out of them, ultrasound will be the first line of investigation due to its availability and the cost. However, the MRI remains the gold standard for imaging of muscles. Later in the discussion, I will discuss about the importance of chest X-ray and HRCT for lung changes. Right. There are three images here. The image now labeled A illustrates the normal sonographic anatomy of the muscle, where there is heterogeneously hypoechoic echo texture compared to the subcutaneous tissues. And in the middle image shows the appearance which is seen in dermatomyositis, where there is increased echo texture of the muscles not only within the muscles, but also in the subcutaneous tissues due to the inflammation. And when there is fatty infiltration, or rather fat degeneration, again, there can be heterogeneously increased ecotexture within the atrophied muscles. However, the subcutaneous tissues show normal ecogenicity. Next slide, Himanta. The MR scan. The MR imaging can sensitively visualize the distribution of muscle involvement, both changes of activity and damage. And like we discussed earlier, the MRI can identify the best site for muscle biopsy as well. Next slide, please. There are several sequences in MR. The fat suppressed T2 weighted or STIR sequence is the very sensitive sequence we used in demonstrating muscle abnormalities that detects the muscle edema and the fascial edema as hyperintense areas. Whereas T1 weighted images are useful in detecting fatty infiltration of the muscle. In T1, when there is fatty infiltration, the intensity is increased. Next slide. Right. This is an example of myositis of bilateral thigh muscles. The coronal reconstruction, as you can see here, is a STIR sequence with bilateral involvement of all the adductors and the quadriceps muscles. The signal intensity is slightly severe in the left side. And the lower down two axial sections shows, again, STIR sequence, which confirms the muscle involvement, and the left side is involved more than the right side. Like I discussed earlier, the T1 sequences, the upper two images in the right side, which does not give any signal change. That is the T1 sequence. Next slide, Himanta. Okay. Again, the coronal reconstruction of STIR sequence, which gives bilateral symmetrical involvement of erector spinae muscles as well as the gluteal muscles of this patient. The next slide. When it comes to fat degeneration, like we discussed, the T1 sequence gives more reliable information. In this patient, the affected side is the left side, where you can see increased signal intensity in almost all the thigh muscles. And there is atrophy. Clearly, you can see the reduced bulkiness of the thigh muscles compared to the normal right side. Next, please. Yeah,
Thank you very much, Dr. Chintaka. Now, we know that histology is immensely important in the diagnosis of idiopathic inflammatory myopathy. So, I will now ask Dr. Harchima Vijayasinghe to explain about the histological changes that are seen.
Thank you very much, Dominda. So here we have a patient with a suspected inflammatory myopathy. We've discussed the clinical presentation, we've discussed the EMG findings, and we've discussed the role of radiology. So what is the role of histology? A muscle biopsy has an important role in the investigation of patients with suspected inflammatory disorders. Before we take the muscle biopsy, there are a few things that we need to consider. One is, what type of biopsy is preferred? Are we going to go for an open biopsy or a closed biopsy? A closed biopsy has a few advantages over an open biopsy. One advantage is that in an open biopsy, the surgeon can visualize a skeletal muscle that he is sampling. He can avoid tendinous areas and subcutaneous fatty tissue. Whereas in a closed biopsy, sometimes fat and fibrous tissue can be inadvertently sampled, which can interfere with the interpretation. Additionally, open biopsies are often larger than closed biopsies. In the closed biopsies, we get only small cores. Inflammatory myopathies tend to be patchy, and therefore they may be missed on a closed biopsy. So overall, if possible, an open biopsy is preferred. Next, we need to select the appropriate muscle. So we need to select a muscle that is involved. So we need to select a muscle that is weak, but it shouldn't be too weak. If there is advanced disease, then the muscle on biopsy will show extensive fibrosis and adipose tissue deposition, which may sort of represent an end-stage muscle. There may be no evidence of the active disease process. Again, that makes it difficult for the pathologist to come to a sort of etiological diagnosis. So we need to select a muscle that is weak, but one that can overcome gravity. As Dr. Duminder mentioned, we need to avoid muscles that have been injured or injected or sampled by neurophysiology, particularly within the last 6 months, because these procedures can result in an inflammatory infiltrate in the muscle, which can confound the interpretation, particularly when you're thinking of an inflammatory myopathy. Then it's best if we avoid muscles like the neck muscles, paraspinal muscles, and hand muscles, small muscles, because these muscles are very rarely biopsied, and the pathologist may not be so familiar with the morphology. So as a pathologist, when we look at a muscle biopsy, we compare it with what we know as normal, what the normal muscle fiber size is, what the normal arrangement is. So it's good if you biopsy a muscle that my pathologist sees often. So if it's from the upper limb, the deltoid or the biceps is preferred. And if it's the lower limb, the quadriceps or the gastrocnemius muscle. These muscles biopsies need to be handled with extreme care. You need to avoid cautery, sutures, or clamping because they can induce artifacts. The sample needs to be transported to the laboratory. It needs to reach the laboratory quickly. It needs to get there within 2 hours. It should be transported fresh, not immersed in normal saline, not immersed in formalin. Instead, the sample should be wrapped in saline-soaked gauze and sent to the lab within 2 hours. If it's not possible to get it to the lab within 2 hours, you can snap freeze a sample in liquid nitrogen and transport it on dry ice. Why is this important? It's important because if the sample is not, if there's a delay in freezing the sample, it can result in freezing artifacts, as is seen in this lower picture. You can see there are tiny vacuoles within the muscle cells. That's due to ice crystal formation, which can result from a delay in freezing the specimen. And this can make it difficult for the pathologist to interpret the biopsy. As with any sample that you send to the histopathology laboratory, you need to provide adequate clinical details. What muscles are involved? How has the disease progressed? Are there any skin lesions? Is there connective tissue disease involvement? Does the patient have a malignancy? Information such as this is very important to the pathologist. Then if serology has been done, if antibody levels are available, again, mention that on the request form. Creatinine kinase levels are useful because if they're elevated, it sort of indicates a myopathy over a neuropathy. And the level of creatinine kinase will also give the pathologist an idea as to the extent of muscle injury, which will be useful in interpreting the biopsy. Ideally, we want the biopsy to be taken before starting steroids because, as you know, steroids mask inflammation. So if the patient has been on steroids, again, the inflammation might be masked, and that might be difficult, particularly when you're thinking of an inflammatory myopathy. So if by chance the patient has received steroids for over 2 weeks, mention it in the request form so that the pathologist can take that into account when they are interpreting the biopsy. And if you have a clinical or differential diagnosis, mention it again on your request form. So once the biopsy comes to the laboratory, we usually receive it in saline soaked gauze or either transported on dry ice. It's processed like any other frozen section. Cryostat sections are cut, and they can be stained with a variety of stains depending on the facilities available in the laboratory: hematoxylin and eosin, histochemical stains, immunohistochemical stains, and even immunofluorescence can be performed on cryostat sections. If facilities are available and indicated, samples can be sent for electron microscopy. If that is the case, the sample needs to be fixed in the appropriate fixative, which is glutaraldehyde. Generally, we do not recommend sending samples in formalin because formalin fixation again affects the morphology of the muscle fibers, making interpretation difficult. So once the biopsy comes to the lab and the sections are cut, we pathologists look at the sample, and there are certain features that help us to distinguish between the different inflammatory myopathies. So in this patient, we are suspecting a dermatomyositis. In dermatomyositis, what do we expect to see under the microscope? It's an inflammatory myopathy, so there will be inflammation. So we'll see mononuclear cells. And in dermatomyositis, the pattern of inflammation is characteristic. It tends to be around blood vessels. In this first picture, you can see the blood vessels, and around the blood vessels, there is a mononuclear cell infiltrate. This mononuclear cell infiltrate is predominantly composed of CD20 positive B cells and some CD4 positive T cells. CD8 positive cells, cytotoxic T cells, are sparse. With inflammatory myopathies, another common feature that we see in all of them is muscle fiber necrosis. The characteristic feature that we see in dermatomyositis is perifascicular atrophy. If you look at picture B, you can see the muscle fibers towards the periphery of the fascicle are small and atrophic in compared to the ones in the center. So that is a characteristic feature of dermatomyositis. So the pathogenesis of dermatomyositis is thought to be related to a vasculitis mediated by anti-endothelial antibodies. And this is evidenced by the fact that in very early muscle biopsies in which other changes are not seen, we sometimes see deposition of complement and membrane attack complexes around the capillaries within the endomysium. So how does polymyositis differ from dermatomyositis? Again, in polymyositis, we see inflammation, and the infiltrate is composed of mononuclear cells. But here, the pattern of inflammation is different. The inflammation is endomysial. In contrast to dermatomyositis, you can see the inflammatory cells here infiltrating between the muscle fibers within the endomysium. The inflammatory cells in polymyositis are CD8 positive cytotoxic T cells. So the type of cell is different. In the inflammatory myopathies, including polymyositis, the muscle fibers express MHC class 1, which is demonstrated in this picture. This is common to most inflammatory myopathies. This is an immunohistochemical stain, and you can see, in contrast to the control normal muscle, there is expression of MHC class 1 on the muscle fibers. So there's inflammation, mononuclear cells, and they're within the endomysial space. Like the other myopathies, there is muscle fiber necrosis. So polymyositis is thought to be brought about by cell-mediated cytotoxicity. You have the CD8 positive T lymphocytes that are invading MHC expressing muscle fibers, causing muscle fiber necrosis. Another important type of inflammatory myopathy is inclusion body myositis. A lot of the features in inclusion body myositis are similar to polymyositis, again, you have a mononuclear cell infiltrate composed of CD8 positive T cells and macrophages. The distribution of the inflammation, like polymyositis, is endomysial, and again, you see muscle fiber necrosis. But here, the characteristic feature is the presence of inclusion bodies, which you are seeing here. So there is a vacuole within a non-necrotic muscle cell, and that vacuole has a basophilic rim, and within that vacuole, there is a inclusion. So if you pick these up, then it sort of clinches the diagnosis of inclusion body myositis. The pathogenesis of inclusion body myositis is not certain. It's thought to be degenerative or maybe immune mediated, and CD8 positive cells and macrophages invading these non-necrotic muscle fibers expressing MHC1 is the main underlying mechanism. So another newly recognized entity of inflammatory myopathy is immune-mediated necrotizing myositis. So this differs from the other three that I described histologically, because the inflammation, if you look here in this biopsy, it's sparse. There's hardly any inflammation. So there's absent or sparse mononuclear cell infiltrates. If there is inflammation, it is composed mainly of macrophages. B cells and T cells are virtually absent. There are randomly distributed necrotic fibers and muscle fibers in various stages of regeneration. And in contrast to the other types of inflammatory myopathy, MHC class 1 antigen is usually not expressed. And this type of myopathy, inflammatory myopathy, lacks the typical diagnostic features that of perifascicular atrophy that we see in dermatomyositis and the inflammation that we see in polymyositis. This is seen in association with viral infections, connective tissue disorders, malignancies, and statin therapy, and thought to be brought about by an antibody-mediated mechanism. So what is the role of a muscle biopsy in myositis? If on our muscle biopsy we see a mononuclear cell infiltrate, myofiber necrosis, and expression of MHC on class 1 on myofibers, it supports the diagnosis of a inflammatory myopathy, because these features are seen in polymyositis, dermatomyositis, and inclusion body myositis, as I just discussed. And by looking at the specific histological features discussed, we can accurately specify the subtype of myositis. The biopsy, in conjunction with clinical features, serology and CK levels, can help to rule out mimics with secondary inflammatory changes such as muscular dystrophies, metabolic, infectious, and drug-related myopathies, and neurological diseases. So the muscle biopsy, remember, although I discussed histological features, it's not interpreted by the pathologist alone. It has to be interpreted in a multidisciplinary setting with input from the clinician, the electrophysiologist, the radiologist. You need to take into account the clinical features, creatine kinase levels, serology, and muscle biopsy findings, put them all together and come to your final diagnosis. So, thank you.
Thank you, Dr. Harshima. Now, I will invite Dr. Amal to brief us on the autoantibody tests that should be done, which are vital in diagnosing.
Yes, getting back to autoantibodies in idiopathic inflammatory myopathies, previous speakers talk about biopsy, EMG findings, and MRI, which are essential part of making a diagnosis. Although EULA classification criteria includes anti-Jo1 to be considered in making a diagnosis, autoantibodies rather supports the diagnosis and prognosticate and phenotype the type of IIM. So there are two types of autoantibodies we come across in idiopathic inflammatory myopathies. The first type being myositis specific autoantibodies, or we call it the MSAs, and the second type being myositis-associated autoantibodies. These are the myositis-specific autoantibodies. The first one being anti-amino-acyl tRNA synthetase, of which subtypes include anti-Jo1, PL7, PL12, etc. The others being anti-MI2, anti-SRP, anti-NDF5, TIF1 gamma, and NXP2, SAE, and HMG-CR, which is associated with statin-induced necrotizing myositis. The second variant, or myositis-associated autoantibodies, are mainly associated with CTD myositis overlap syndrome. For example, anti-PMSCL is seen in myositis systemic sclerosis overlap syndromes. Rest of the autoantibodies or myositis-associated antibodies are anti-Rho52, anti-LA, anti-SINRP, and anti-COO. So what is the role of autoantibodies in idiopathic inflammatory myopathies? It is very rare for more than one MSA to coexist in the same individual. So this is a potential place to use to precisely define genetic and disease endotypes. Each MSA is associated with a distinct pattern of disease or phenotype. Therefore, it has implication for diagnosis and to plan out a personalized approach to therapy, and also has a implication of prognostication and predicts the extramuscular manifestation. I will talk about this in my next two slides. When you diagnose a patient with idiopathic inflammatory myopathy, it is always useful to have a look at the ANA pattern, because the pattern itself gives clues to where you point towards, or the myositis panels that you might need to request for. For example, ANA with a nuclear pattern is seen in MI2 subtype, SAE subtype, NXP2 and TIF1 gamma subtypes. Cytoplasmic pattern is seen in the necrotizing myositis in HMG-CR and SRP type, and also in antisynthetase syndrome and MDF5. What is seen in the CTD overlap syndromes are mainly a nucleolar pattern. Then the second thing is autoantibodies or myositis specific antibodies may phenotype the disease type and prognosticate, and also provide clues about the extramuscular manifestation. For example, SRP and HMG-CR autoantibodies would result in a necrotizing myopathy. Similarly, SRP would give rise to a severe myopathy and would have dysphagia. Skin manifestations are common in these myositis subtypes. SAE, MI2 gives rise to a classical dermatomyositis picture, whereas MDF5 gives rise to the reverse Gottran signs and skin necrosis. Calcification is seen in NXP2 subtype, and TIF1 gamma type, it would be more of an erythrodermic picture. And these two, NXP2 and TIF1 gamma, are associated with has a high risk of malignancy. Then when it comes to lung disease, antisynthetase subtypes, MDF5 and PMSCL are associated with the lung involvement. And the other thing is, we can also predict the prognosis by looking at the myositis antibodies. For example, MI2 has a good prognosis and would give rise to or lesser chance of having interstitial lung diseases or malignancy associated, myopathy associated malignancies. Whereas TIF1 gamma and NXP2 would have a higher risk of malignancy and thereby a poor prognosis. And at the same time, if you come across a MDX5 subtype, what it would say is these are more common in amyotrophic dermatomyositis, and what the clinician actually needs to do is to look for a rapidly progressive lung disease. And also, if you come across a necrotizing myopathy with SRP and HMGCR, they might be resistant to treatment. So likewise, we can prognosticate and also phenotype the idiopathic inflammatory myopathies further. So getting back to our patient, this is the summary of the investigations. She had a normal urine full report and full blood count was normal. ESR, there was a moderate elevation in ESR and CRP. CPK was 13,200. She had normal electrolytes. Her AST was more than the ALT, partly because of the muscle activity. TSH was normal. We performed ANA with pattern. There was a nuclear pattern. They suggested to go ahead with MI2, TIF1 gamma, and NXP2 antibodies. In her case, anti-Jo1 was negative. Unfortunately, we were not able to get done a myositis panel. Her chest X-ray, there were no features of ILD. Initial ultrasound abdomen, there was no organomegaly, and ultrasound scan of the breast was normal. EMG demonstrated the myopathy pattern in right-sided rectus femoris, vastus lateralis, bicep and deltoid muscle groups. We went ahead with a muscle biopsy according to the principles Dr. Harshima described, and this was taken from the left vastus lateralis muscle, and there was features of underlying dermatomyositis in the HNE state with vascular infiltration and perifascicular atrophy. So getting back to the diagnostic criteria, this patient fulfilled, ticked all 5 boxes in the Bohan-Peter criteria, making a definitive diagnosis of dermatomyositis. And we also looked at the classification criteria there. She scored 22 in the graded scoring system with a definitive diagnosis of idiopathic inflammatory myopathy with a probability of 100%, subtype being the dermatomyositis.
Thank you, Amal. Now that we have a definitive diagnosis, I would like to turn to Dr. Duminda Munidasa to speak about the management of idiopathic inflammatory myopathies.
Yes, thank you, Himanta. Yes, the management, we generally are guided by different guidelines provided by the worldwide the associations. The latest we have is from the BSR, British Society for Rheumatology. It's actually nice accredited. So we know that generally when the nice accredited, they look at the cost effectiveness as well. So which might be very helpful in our setup also, with, especially with all the economic constraint now we are having in Sri Lanka, as maybe in most of the countries in the world. And this and previous guidelines by the other societies in rheumatology will be helpful. So of course everybody knows that the management is the first step is high dose glucocorticoids. It is crucial for remission induction and maintenance, and generally what we prefer to start with oral steroids at about 0.5 to 1 milligram per kg per day, and then try to taper it out. Generally guideline is to taper it in and around 6 weeks, looking at the clinical response mainly, and maybe also at the CPK levels. We might use high-dose glucocorticoids as intravenous methylprednisolone, especially when you have very severe limb muscle weakness. If the patient is having dysphagia or respiratory muscle involvement with impaired the single breath count type as well, and also if there's a concern about the GI absorption of the steroids. And generally what I use is about 1 gram of methylprednisolone daily for about 3 days, and then go into the oral full dosage. And it is thought that it may allow increased therapeutic effect and less toxicity compared to the oral glucocorticoids if you use initial IV methylprednisolone. The integral part of this treatment should be combined with disease-modifying antirheumatic drugs as starting early as possible. It has shown to reduce the muscle inflammation, achieve clinical remission and maintenance, and also reduce the steroid burden. There are no trials which say which one is better, and even the recommendation doesn't say this is better. There are options of using methotrexate, azathioprine, tacrolimus, cyclosporine, or MMF. My preference is generally with methotrexate. Of course, interestingly, the practical issue we get is invariable these patients have AST and ALT, so we wonder whether we can start on methotrexate. But my general guide, I am guided by the ultrasound scan of abdomen where the liver is not showing any effect. I would, even with a high AST/ALT in this setup, will start on methotrexate, but have a close monitoring of that to see whether there will be a rise soon after we start on methotrexate. But generally, it works well, and it when the CPK start coming down, the AST/ALT comes down. The use of this, especially when you have very severe disease or refractory to the initial treatment, the options available are cyclophosphamide or intravenous immunoglobulin. Again, the immunoglobulins are pretty expensive, so again my choice will be for cyclophosphamide using as pulses and then changing into a maintenance with the possibly MTX or methotrexate. Rituximab is also been now coming to the forefront, especially when it's juvenile onset disease or patient with positive myositis antibody profile, specifically depending on the severity, prognostically worse ones, and patients with lower burden of disease damage. Abatacept is also been shown in trials to be useful in refractory idiopathic inflammatory myopathies. Number 3 in management should be giving a physiotherapy and occupational therapist involvement to make a better functional outcome long term. Starting this early should be very useful, but it has to be a safe and appropriate exercise program depending on the severity of the disease. You might decide when to start, but need to be started early. You can start without weight bearing, like sort of using the technique like suspension therapy for these patients. Of course, in Sri Lanka, we are at advantage because all of our rheumatologists are board certified in rehabilitation medicine as well. And we have our own physiotherapy and occupational therapy departments with our units. So we have a better access to them to start and manage our patients, to cutting down the possible functional disabilities which these patients can end up if we don't use this mode of treatment. Coming to skin manifestations, here what our patient had, what we get in Sri Lanka is this dark pigmented rash of dermatomyositis in the sort of well-known areas, which I'm sure, but it cannot be described as in the books of saying that this is a pinkish or erythematous rash, or even sometimes it's difficult to say whether it's heliotrope rash, because we are dark colored skin population compared to the light colored skin. So we have to appreciate in this country and probably our Asian neighbors that this may, what we have to describe is typically seen as a pigmented rash. So just for a break, will this doing a biopsy in the skin of this dermatomyositis patient be any help for our diagnosis purpose? I would like to ask Ashima to briefly tell us about that.
Yes, so a skin biopsy would help to a certain extent. The changes that we see in a skin biopsy from a lesion of dermatomyositis are not specific. But typically what we would see is an interface reaction pattern where we see changes along the dermo-epidermal junction, that is the interface between the epidermis and the dermis. So we see vacuolation of the basal keratinocytes. So if you look carefully, there is some clearing in the cytoplasm of these basal keratinocytes. We might see some pigmentary incontinence, where the pigment that is normally present in the basal keratinocytes moves down into the dermis, and there might be inflammation along the dermo-epidermal junction. The inflammatory infiltrate also tends to aggregate around the blood vessels in the dermis, so we see a mild perivascular lymphocytic infiltrate as well. And the dermis contains increased amounts of mucin, and we can show this by doing a special stain called Alcium blue, in which the mucin stains blue as seen in this smaller picture. So these changes that I have described are not specific. They can be seen in other conditions such as lupus erythematosus. So the changes are not diagnostic, but in a patient with a skin rash that is suggestive of dermatomyositis, and in whom you have that clinical suspicion, the presence of these features and by correlating the pathological and clinical features together, we can make a diagnosis of dermatomyositis. Over to you.
Thank you, Harshima. Probably when we have this clinically myopathic dermatomyositis, it may be helpful, especially if you have the typical rash and just for a confirmation what's going on. So when it comes to management of skin manifestation, especially, treatment is same as what we described earlier, but if there are refractory skin to general treatment of glucocorticoids and conventional synthetic disease modifying drugs, recommendations are to try with rituximab, IVIG, and also important should be paid to the sun avoidance and use of broad spectrum sunscreens to reduce the likelihood of disease activation by excessive sun exposure. So actually interesting is not only the skin, even the muscle can get activated by excessive sun exposure in this patient, which is something we have to remember in our parts of the world. The next one which is important is of course the associated interstitial lung disease, which can come in our patients. It's recommended screen for this in all our patients, especially the high risk patients who are the older age at diagnosis. If the patient is having arthritis, arthralgia, fever, in addition to muscle and skin changes, presence of antisynthetase associated antibodies and anti-MI2 antibodies, and if the ESR and CRP disproportionately elevated, and or if the overlap, especially with the scleroderma, is there. So generally what the recommendation is for screening is with the plain chest X-ray, pulmonary function test including BLO and maybe the 6-minute walk test, and where indicated HRCT. So I'd like to ask Chintaka to expand on what we may do and what we'll see on these. So over to Chintaka.
Thank you, Dr. Dominder. So the lungs are the most common extramuscular organ to be affected in dermatomyositis. Approximately 40 to 50% of patients with dermatomyositis suffer from its pulmonary complications. This can manifest as like interstitial lung disease or sort of pneumonia conditions, drug-induced lung diseases, and ventilatory muscle weakness related conditions. Next slide. We can start with chest X-rays as the first line investigation, and followed by HRCT where indicated. And HRCT is straightforward. There is no preparation is needed. Both inspiratory and expiratory phases will be valuable in evaluation. Next slide. This is one such example of a chest X-ray in an affected patient, where there is increased fine and coarse reticulation predominantly involved in the mid and lower zones. As you can see, the heart and the diaphragmatic borders are shaggy due to the affected lungs. And there is little bit of relative reduced lung volumes as well. But there are no areas of consolidations or pleural effusions or cavitations or other related interstitial lung findings. Next slide. The HRCT clearly described and shows the subpleural predominance and the lower lobe involvement. As you can see, this is symmetrical, and most of the findings are confined to the lower lobes. Next slide. The same patient, coronal reconstruction, again demonstrates the lower lobe predominance, and there are fine and coarse reticulations. However, in this patient, there is no honeycombing or cavitations. Next slide. Again, at the same patient, the sagittal reconstruction confirms the distribution of the lung involvement. Next slide. The findings can vary depending on the phase of the disease, such as in this image demonstrate the subacute phase. There are areas of consolidation and ground glass opacities involving the lower lobes, and again subpleural location. Many years later, the same patient, the involved areas are replaced with permanent lung changes with fine and coarse reticulations, and here you can see the honeycombing. So that is established ILD. However, in the latter stages, we don't see the acute inflammatory changes such as consolidations or pleural effusions. Over to you, Himanta.
Thank you, Chintaka, for that update on what we might see in our HRCT and chest X-ray and HRCT. So when it comes to treatment of ILD, there will be what we call rapidly progressive ILD in these patients, or chronic ILD, chronically slowly progressive ILD. So here, if it's rapidly progressive, it's the same treatment. We use induction therapy with high dose steroids, and then the cyclophosphamide or rituximab therapy to be considered early in these patients if you are not already used for other reasons. Other options are cyclosporine and tacrolimus and to be used, and patient with chronic so the ILD, the steroids with or without disease modifying drugs can be used. If you are adding a disease modifying drugs, the recommended are azathioprine, cyclosporine, tacrolimus, and MMF, and rituximab or cyclophosphamide as treatment if is resistant. So generally, going by the evidence for other connective tissue disease related ILD, we at the moment prefer MMF or azathioprine as our treatment in these patients. Now, the important involvement of the organs in inflammatory myopathies is cardiac involvement, which may be masked at the beginning and may not detect, but suddenly they might go into a heart failure due to cardiomyopathy which develops. There is increased morbidity and mortality risk when the cardiac myositis is involved. So patients should undergo screening in these for the cardiac involvement as well. It can be, the screening is recommended serum cardiac damage markers, especially cardiac troponin I, not the troponin T, as the muscle also can put out troponin T. ECG, echocardiogram, and cardiac MRI, if really indicated, are the other ones whereas you use as a screening methods. Another often overlooked problem is sort of asymptomatic dysphagia they might be having, leading to aspiration sometimes. It's supposed to be common, though we generally have not looked into it. It will affect the quality of life and associated with weight loss and aspiration pneumonia. So this may not really related to how much weak your other muscles are. So all patients should screen for this as well. And there's an increased risk with XPA2 and positive or with the associated malignancies. So how you will screen for that? You have to routinely inquire from the patient whether there's dysphagia related symptoms. Involve your speech and language therapist to do a swallowing assessment. And if it's recognized to be there, the immunotherapy should be given. Actually, the IVIG has special space for that people who have severe dysphagia. You might use with the steroids, the common drugs we use. And again, cyclophosphamide and rituximab for people who are non-responders. So over to Amal.
Yes, getting back to our patient, her management wise, we initiated a multidisciplinary team management for remission induction. Since she had a severe muscle weakness, an MMT score of 99, I have initiated with the IV methylprednisolone 1 gram over 3 consecutive days, followed by commencement of oral prednisolone 60 milligram daily. Then simultaneously, I have commenced her on methotrexate 10 milligram weekly and slowly escalated with close monitoring of liver functions. From dermatology point of view, they had started her on UV protection with SPF 50 sunscreen, and according with their guidelines, they have commenced her on hydroxychloroquine as well. Early referral to the therapy team was made to commence on physiotherapy and occupational therapy. With these, she had initially a good response, where within a month's time, her CPK was lowered from 13,200 to 4,000. But thereafter, despite adequate immunosuppression and clinical improvements, her CPK started plateauing. So this was in December. By January, her CPK was 4,210. But over the next 3 to 4 months, her CPK was plateauing around 4,000 to 2,000 region. Her MMT score was back in December 21 was 99, and it remained or was stagnant at 97 in March 22. So then I looked into the possibilities for this unsatisfactory response to immunosuppression therapy. Have I done a suboptimal is the immunosuppression suboptimal? Do I need to escalate treatment with IVIG, rituximab, or cyclophosphamide? Have I missed an underlying malignancy at first place? Or are we dealing with the inclusion body myositis? The latter is the least possible one, since there was the EMG was not supportive towards inclusion body myositis. At the same time, muscle biopsy was more in favor of dermatomyositis. Prior to immunosuppression escalation, I have decided on screening for underlying malignancy again, and she went with a repeat ultrasound scan where there was a right-sided adnexal mass, which was queried as an ovarian tumor. She also had a CA125, which was positive, and CT abdomen and pelvis revealed a right-sided ovarian malignancy. So, bit about malignancy in idiopathic inflammatory myopathy. In comparison with normal population, patients with idiopathic inflammatory myopathies have a higher risk of malignancy. In dermatomyositis, this risk increases, or this is seen in up to 30%. The malignancies associated are mainly solid organ tumors, which are lung, ovary, breast, or colonic cancers. In malignancy associated or cancer associated IM, the patient may be resistant to the standard treatment, but usually responds to the treatment of cancer. With the relapse of cancer, they might develop or they might have a development or relapse of myositis. Then how are we going to screen these people or patients with myositis for a possibility of underlying malignancy? Here, standard age-appropriate guidelines may not be adequate for cancer screening in idiopathic inflammatory myopathies. At the same time, screening all patients for malignancy might not be practical. Still, there is no clinical consensus regarding screening, but should be considered in those with high-risk factors. Who are these people with high-risk factors? Old age at the onset, male gender, dysphagia, presence of cutaneous necrosis, as in our case, resistance to immunosuppressive therapy, rapid disease onset. When it comes to antibodies, presence of anti-TIF1 gamma antibodies, positive anti-NXP2 antibodies, and negativity for other well-known MSAs are considered as risk factors. In some literature, it is recommended that patients with dermatomyositis, as well as patients who do not have interstitial lung disease, to have a low threshold for malignancy screening. This study, which was published in Rheumatology Journal in 2019, done by Professor Hector Chinoy and et al., gives some very important conclusions regarding the temporal relation between cancer and adult onset anti-TNF TIF1 gamma antibody associated dermatomyositis. The conclusions they came up with are anti-TIF1 antibody positive dermatomyositis is associated with an increased risk of malignancy, particularly ovarian cancers. This increased risk is only present in the 3 years on either side of the diagnosis of the dermatomyositis. That is, either from the diagnosis, after 3 years, you can see the cumulative incidence or prevalence plateaus. And this can also be seen 3 years preceding the diagnosis of dermatomyositis. And this associated is significantly seen in patients above the age of 39. So finally, what happened to our patient? Urgent referral to gynecological team was made, and she successfully underwent a total abdominal hysterectomy and bilateral salpingo-oophorectomy. With that, we were able to tail off her steroids completely over the next 2 months, and her skin lesions also regressed, and CPK was normalized by the end of June 2022. I still continue to use a low-dose methotrexate, but the optimal duration of continuation of methotrexate is not specified, so I would try to de-escalate it over the next couple of months. So in summary, ladies and gentlemen, idiopathic inflammatory myopathies are a heterogeneous group of rare autoimmune muscle disorders characterized by primarily a symmetrical proximal muscle weakness. Other myopathies may have clinical features and investigation findings common to IIMs. Electrodiagnostic tests should be an extension to the clinical examination, history taking and examination. Clinicopathological correlation with EMG, MRI, and biopsy is an important part of the making a diagnosis. Myositis-specific autoantibodies are associated with distinct phenotypes and are important in prognostication. Early aggressive therapy with steroids, DMARDs, rehabilitation team is important for good functional recovery. Screening for dysphagia, cardiac muscle involvement, interstitial lung disease, malignancy appropriately is important in reducing morbidity and mortality. Dermatomyositis, there is an increased risk of malignancy compared to general population. MSAs can point toward malignancy-associated dermatomyositis. Finally, standard age of period guidelines may not be adequate for screening IIMMs. Therefore, we may need a low threshold and frequent surveillance screening in high-risk groups. Thank you very much. Over to you, Himantha.
Thank you very much, Amal. Now we will start our Q&A session. Due to time constraints, we can entertain only a very few questions. So my first question is, there's a question on use of hydroxychloroquine in dermatomyositis. Any special remarks about this? Over to our guest faculty.
Yes, Himantha, I think hydroxychloroquine use in dermatomyositis has come extrapolating from its use in SLE skin manifestations, where it has worked very well. And it's been used in dermatomyositis, especially when you have skin, as also I think it's been mentioned in when they have severe dysphagia as well. And maybe sometimes it seems to be working in polymyositis itself. The interesting fact about HCQ in hydroxychloroquine, this issue is they have found increased skin manifestation which occur with hydroxychloroquine itself when it's used in dermatomyositis. Almost about 15 to 20% of patients supposed to be getting it, and now it's been said that actually the autoantibody phenotyping may play a part, especially it been seen in more with MDF5 and SAE anti-SAE positive patients. So anyway, the advice is if you are giving hydroxychloroquine in this patient, just warn them that they might get an increased skin lesion, then to stop and come and see again, get a review of the problem.
Yes. So there's another a bit of a tricky question. Now, can we give methotrexate as the additional immunosuppressive agent if gamma GT is normal on the background of elevated transaminases? What is your opinion?
Yes, I think that's what I spoke about, that it's a very interesting situation where I use it because it has very big role to play in reducing the functional bad outcomes. So yes, one is ultrasound, the other is the gamma GT could be a good indicator to say that it is safe, but probably you will have a better follow-up of close follow-up of your enzyme levels when you start on methotrexate. I think that's the good idea. Amal, any?
Only thing is the gamma GT sometimes may be, again, gamma GT and alkaline phosphatase may be elevated because of the acute phase reactant effect. So even that, in that instances, if the ultrasound does not reveal any fatty liver disease, we might go ahead with methotrexate with close monitoring. If you have a suspicion of, because this might be associated with autoimmune hepatitis, in that case, we might need a early GI physician referral and a liver biopsy to rule out a possibility of underlying autoimmune hepatitis.
Thank you, Dr. Amal. Now, with that, we might have to end our Q&A session because of the limitation in time, but we won't disappoint all the viewers who post questions, because we have a format where all the questions can be answered. I will explain that. Now we have this APLAR Grand Round bundle, where there's this APLAR Grand Round forum and APLAR background So the APLAR Grand Round forum is where you could post any new questions and also initiate a nice discussion about today's case and myositis. So all our viewers can post any question in this forum, and we will be very happy to answer these, and all the questions that we have had loads of questions flowing in. So all these questions will be answered in the APLAR Grand Round forum. And also now we have the APLAR Blackboard. So APLAR Blackboard is a way of interacting and testing your knowledge on myositis. So you can visit the APLAR website, and under the APLAR Grand Round, the theme, the sub heading, you will find the APLAR Blackboard, where 2 questions await you. The detailed answers are also available at the end of the quiz. The same link can be used to enter the APLAR Grand Round forum as well. Then yes, so now I would just like to remind our viewers that the next APLAR Grand Round will revolve around rheumatoid arthritis, and experts from Pakistan will share their experiences with us on the 29th of October, that's in 2 months' time. And please help us to improve. Scan the QR code and just help us to improve by penning your thoughts, and fill the review form by clicking on the QR link. On behalf of APLAR and the Sri Lankan panel of experts, I wish to thank all our viewers for taking part in today's Grand Round. Have a pleasant weekend, and bye.